So now that we've talked a little bit about why outcomes are important, let's change our gears a little bit and talk about the challenge of choosing the right outcomes. And this becomes key in this role. And so you can see that choosing the right outcomes might become a daunting task. Let's look at the number of measures just for one body part, in this case, the shoulder. And as you can see here, there's a long, exhaustive list, which can really make somebody confused when they're trying to figure out, well, which one should I use and what's important. And so this is where building a consensus around outcome measures really becomes important. And Michael Porter at Harvard has done much of this work already when it comes to standardizations. And he has been a significant driver in this movement. Standardization is allowing comparisons that will accelerate care improvement, and it also allows providers to collect and share data on outcomes more efficiently.
One other thing, standardization, or which forms are popular, how much data exists for certain outcomes measures. That's certainly a key variable in deciding which outcomes measure to use. There are other variables as well to consider. Things like what scores do the outcome measures produce, right? We talked about pain, quality of life, function, and those types of scores. Who else is using it, right? So how much data exists? Is there licensing required? So many outcomes questionnaires aren't going to require licensing, or they won't cost anything. Some of them, that's not the case, right? So that's just something else that you'd want to navigate. And then from the patient perspective, if this is all patient-reported data, then how many questions are we asking them to get the data that we need to improve the value chain, right? So lots of things to consider when you're looking at the list of outcomes questionnaires available.
So talking a little further about the challenges, and here are some of the reasons why those challenges exist. There's a patchwork of measures and definitions, meaning there's so many out there that don't really correlate to each other. There's so many different kinds of institutions and players involved, like provider organizations, specialty societies, and individual clinicians that really don't allow for comparison because they're all using different tools. And then there's few regional, national, and global standardized mechanisms, which leads to an arduous process of agreeing on how to measure these things and what exactly is important to be measured. So the benefits of this standardization is it's allowing us to create a large uniform data set. If everyone is collecting the same information, we can now compare that information. It's also allowing providers to share the outcomes more efficiently by being a part of a registry or being part of an association where they can look at outcomes not just from one provider, but from a large amount of providers and surveys from a large amount of patients. It also allows comparisons that will accelerate care improvement by figuring out what's working.
And so just to loop some of these benefits back directly to your practice, when you standardize the collection of patient-reported outcomes and you're able to create a large uniform data set, that means that what you can do is you can contextualize your patient-level data within that data set, which then is going to allow you to provide increased care, which under this new payment program means increasing your bottom line, right? Same thing with being able to compare outcomes across different practices, right? So you can better understand or contextualize your practice within the healthcare landscape, as well as looking at that data set, this large data set, and understanding the healthcare landscape at a high level.
So let's look at a few examples of some organizations that are making that movement towards standardization. The first being AAOS, which is the American Academy of Orthopedic Surgeons. And this academy is the preeminent provider of musculoskeletal education to orthopedic surgeons and others around the world. In 2015, they formed the Quality Outcomes Data Work Group to investigate and evaluate the collection of data tools. And they used a set of specific criteria. And so here's the list of criteria that they used. For the first being an open access to patient-reported outcome measurements, meaning that they chose instruments that don't require a fee for using. It's free for all. The second is patient-reported outcomes only, meaning this data is coming directly from the most reputable source, and that's the patient themselves. It's not being entered by a second party. There's multiple entry platforms such as digital, paper, or web, which allows for increased compliance for patients to fill out this form at their ease. There's approximately 20 or less questions, which also increases compliance by not overburdening the patients with having to answer a questionnaire that has 80 questions on it. They're clinically meaningful, and there is one generic quality of life patient-reported outcome that can be used across all different specialties. And there's no more than 3 joint or disease-specific patient-reported outcomes, and this becomes important as you've seen the exhaustive list of just shoulder joints. And there's also a CAT version that's available, which is the preferable one. And what it does is, based on how the questions are being answered, we can reduce the amount of questions that are answered overall, still keeping the outcomes survey validatable. So here's just an example of the different forms that are available for use through the AAOS site. And as you can see, they're specific to orthopedic and specific to different joints. There are subspecialties within the orthopedic subspecialty itself. And each one of these houses functional outcomes. And there's about 20,000 physician members that are using this standardized list, which is really providing a rich data set instead of having 20,000 providers using 20,000 different forms.
One other thing to note about this list is if under each subspecialty, you'll notice that there's going to be a shortened version of most of these questionnaires. So for example, under the knee option, under the knee osteoarthritis option, there's the KOOS, then there's also the KOOS Junior. Same thing with the dash, right? There's the quick dash. So we talked a bit before about wanting to consider the number of questions that you're asking a patient to get useful data. So just note that there are shortened versions of most of the forms that are included on this list.
So let's take one last look at this comparison of how standardization has really demonstrated the power that it brings here in reducing this numerous survey lists down to ones that really matter the most and ones that everybody can use generally and come to a consensus.
Right. Essentially, I think what we're saying here is that the hard work has already been done for us, right? So there's this long list, and there's all these long list of outcomes measures, and there's all these things to consider. Well, consortiums like AAOS have already done the work for us, right? They have already picked out the ones that are free to use. They apply well to orthopedics. They generate useful data, which is why these forms are so useful.
And this is the primary reason why OBERD chose to align itself with, by and large, the world's largest orthopedic database. So here's another example, and this is the International Consortium of Health Outcomes Measurements. And they are comprised of research-based thought leaders. And Michael Porter, that we mentioned before, is actually one of their founders. And their thought or their belief is based on a book he wrote with a colleague called Redefining Healthcare, where they outlined an argument for using health outcomes data to really redefine the nature of competition in healthcare, therefore driving improvement. And they're done at more of a macro or global level. As you can see here, it's not just one specialty, but different specialties across the board. And what they're really trying to do is unlock the potential of value-based care by defining a global standard set of outcomes that really matter the most to patients. So Oxford University is another example, and they're done at a little bit more of a micro level than ICHOM operates, and their strategic plan was pretty much to lead the world in research and education to benefit the society on a national and a global scale. And what they do is they use university research and students, and they help them to apply their expertise and research for a wider social and economic benefit. And they have a growing portfolio of clinical outcome assessments and patient-reported outcome measures that are focused a little bit more on population health. Oh, and then the last one we have here is PROMIS, which stands for Patient-Reported Outcome Measurements Information System. And they're a little bit more individualized or patient-centered measures that really evaluate a holistic approach of looking at the patient from a physical, mental, and social point of view in both adults and in children. And they're designed to enhance the communication between the clinician and the patient. And they also have CAT versions available.